Picture this. A 58-year-old man walks into your clinic, heavy smoker, 30-pack years. He had a low-dose CT 18 months ago that was clear, and neither you nor he can remember when the next one is due. Sound familiar?
Extremely familiar. Lung cancer screening adherence is abysmal. Over 14 million Americans are eligible, but uptake sits between 20 and 50%. And in Australia, the National Lung Cancer Screening Program launches in July 2025, so this is about to become our problem on a national scale.
Which is why a trial published this week in JAMA Internal Medicine is so timely. Karen Wernley and colleagues at Kaiser Permanente, Washington, ran a pragmatic randomized trial testing 2 interventions to boost annual lung cancer screening adherence. 1,837 patients with a previous clear scan, randomized to usual care, health communication only, stepped reminders only, or both.
So what exactly is a stepped reminder? Walk me through the intervention.
It's elegantly simple. 4 weeks before the annual scan is due, the primary care doctor gets an alert to order it. Then the patient gets messages through the patient portal and by mail telling them to schedule. 2 steps. Provider first, then patient.
And the health communication arm was different?
Yes, health communication was a one-time message 3 weeks after the index scan, reminding them the next one was due in 12 months. More educational, less systematic, no provider alert.
Which makes sense as a comparator. Education alone versus a structured reminder system. What happened?
A stepped reminder was dramatically effective. Screening adherence jumped to 75.5% compared to 47% without it, a relative risk of 1.59. And here's the kicker. Nearly half the trial participants were current smokers, and the reminders worked even better in that group. 73% adherence versus 41%, a 32 percentage point absolute improvement.
That's remarkable. Current smokers are historically the hardest to get back for repeat screening. They're the ones who need it most, and the intervention reached them effectively. But I have to ask about generalizability. This was Kaiser Permanente, an integrated system with a patient portal and electronic ordering. Would this work in Australian general practice?
That's the right question. The infrastructure matters. In Australia, GPs don't have a built-in reminder system tied to a single health network, but the principle translates. Setting up an annual recall in your practice software, flagging eligible patients, and having a nurse or admin person proactively call them. The trial proves the concept. The implementation is up to us.
And interestingly, the health communication arm actually did slightly worse than no intervention. 59% versus 63%. Why would education make things worse?
The author speculated that a generic educational message without a clear call to action might create a false sense of having addressed it. Patients think, I've been informed, I'll deal with it later, and then they don't. The stepped reminder works because it removes the friction. The doctor orders the scan, the patient just has to show up.
That's a profound insight. Information alone doesn't change behavior. System design does. This connects to something we keep seeing across medicine. Adherence is an engineering problem, not an education problem.
Exactly. Bottom line, when the Australian National Screening Program rolls out, build the recall system before the first patient walks in. Don't rely on patients to remember. They won't.
All right, let's shift gears. Story 2, migraine.
You know the patient. 45-year-old woman, 15 migraine days a month. She's tried propranolol, didn't help. You're deciding between topiramate and a CGRP antagonist. What do you choose?
That's one of the most common decisions in GP neurology, and until now, we've had no head-to-head trial comparing an oral CGRP antagonist against a conventional preventative like topiramate.
Enter the Temple trial, published in Lancet Neurology in July, Phase 3b, randomized, double-dummy, active-controlled, 540 adults with at least 4 migraine days per month, across 12 countries. Atogepant 60 mg daily versus topiramate at the highest tolerated dose, up to 100 mg, 24-week double-blind period.
Double-dummy is important here. Both groups took pills, but one group got Atogepant plus placebo topiramate, and vice versa. That maintains blinding, even though the drugs have very different side effect profiles. Smart design.
The primary endpoint was tolerability, measured as discontinuation due to adverse events, and the result was striking. 12% of Atogepant patients stopped due to side effects, compared to 30% on topiramate, a relative risk of 0.4. Atogepant patients were 2.5 times more likely to stay on treatment.
And efficacy? Because tolerability without efficacy is meaningless.
Atogepant was also more effective. 64% of Atogepant patients achieved at least a 50% reduction in monthly migraine days, compared to 39% on topiramate, and the absolute reduction in migraine days was greater, 6.3 fewer days with Atogepant versus 4.5 with topiramate.
So Atogepant wins on both tolerability and efficacy. That's a clean sweep. But I need to be critical here. Who funded the trial?
AbbVie, which manufactures Atogepant, so we need to be aware of that. But the design was rigorous, double-blind, double-dummy, active comparator across 12 countries, and the result is consistent with what we know mechanistically. Topiramate has a broad mechanism that causes cognitive side effects, weight loss, paraesthesia. Atogepant specifically blocks the CGRP receptor, which is directly implicated in migraine pathophysiology. A targeted therapy should have fewer off-target effects.
The PBS angle matters here too. Atogepant is not PBS listed in Australia. Topiramate costs about $12 a script. Atogepant would be a private prescription. So for now, topiramate remains the default for most patients, but this trial gives you the evidence to support Atogepant if the patient can afford it or has private cover.
And for patients who fail topiramate due to side effects, which is a third of them based on this trial, Atogepant is your evidence-based alternative. Remember the number, 1 in 3 patients on topiramate will stop because they can't tolerate it.
Story 3, something every GP deals with, stopping antidepressants.
A patient comes in, she's been on sertraline for 2 years, depression fully resolved, she wants to come off it. What do you actually do? The guidelines say taper gradually, but how gradually? And does psychological support during the taper actually matter? matter?
This is one of the most common clinical questions in general practice, and the evidence has been remarkably thin until now.
A network meta-analysis published in Lancet Psychiatry earlier this year is the largest and most rigorous analysis of antidepressant deprescribing to date. 76 randomized trials, 17,379 participants, all with fully or partially remitted depression or anxiety.
76 trials. That's a serious evidence base. What were the comparisons?
5 strategies: abrupt discontinuation, fast tapering, meaning 4 weeks or less, slow tapering, more than 4 weeks, dose reduction to half or less, and continuation at standard dose, each with or without psychological support.
And the headline finding?
Slow tapering combined with psychological support was as effective as staying on the antidepressant. The relapse risk was nearly halved compared to abrupt discontinuation, number needed to treat of about 5, and importantly, fast tapering and abrupt discontinuation were clearly the worst strategies. 1 in 5 relapses could be prevented by using slow tapering plus support instead of just stopping.
That's a clean clinical message. But I want to probe, what counts as slow tapering? 4 weeks is arbitrary. Some patients need months.
The authors found that very slow tapering, defined as more than 12 weeks, was effective but only when combined with psychological support. Slow tapering alone, without therapy, did not significantly differ from abrupt discontinuation, so the psychological support is the active ingredient, not just the slow schedule.
That's a crucial point. It's not just about how slowly you reduce the dose. It's about having structured support during the process. CBT, mindfulness, even regular check-ins. The combination is what works.
And there's a practical implication. When a patient asks to stop their antidepressant, don't just give them a tapering schedule and send them on their way. Refer them for concurrent psychological support. Even brief CBT sessions during the taper can make the difference between successful discontinuation and relapse.
There's a system-level challenge, though. Access to psychology is difficult in Australia, especially in rural areas. Mental health treatment plans give 10 sessions per year, but waitlists are long. What's the pragmatic version of this for a rural GP?
The pragmatic version is regular structured follow-up. Book the patient every 2 weeks during the taper. Use those visits to provide brief CBT-informed support. Review symptoms systematically using the PHQ-9. And if you have access to a psychologist, even via telehealth, use them. The trial proves the concept. The implementation needs to be adapted to what's available.
Last story. Something for your wife, and for your anesthesia practice.
You're doing an elective cesarean. Spinal. The patient is nervous about postoperative pain. You give dexamethasone for nausea, 4 or 5 milligrams intravenously, but would a higher dose 25 milligrams meaningfully improve analgesia?
High-dose dexamethasone has been shown to improve postoperative analgesia in non-obstetric surgery. The anti-inflammatory effect reduces surgical stress response, but obstetric anesthesia is different. The dose reaches the baby, and the evidence has been lacking.
The British Journal of Anesthesia published a trial this year. 210 women randomized to high-dose dexamethasone 25 milligrams after birth and again 24 hours later, or low-dose 5 milligrams, which is standard, double-blind, 2 centers.
What did they find?
High dose did reduce pain scores. Pain on movement was lower, 2.7 versus 3.1 on the numerical rating scale. Pain at rest was also lower. And functional recovery scores, opioid consumption and rescue analgesia were all better in the high-dose group.
But those effect sizes are small. A 0.4-point difference on an 11-point pain scale. Is that clinically meaningful?
The authors were honest about this. They concluded that while high-dose dexamethasone improved analgesia, the improvements were small and clinical relevance is questionable. They explicitly said they do not recommend routine use. This is a refreshing example of authors not overselling their findings.
So the bottom line for the practicing anaesthetist or obstetrician is this. High-dose dexamethasone is not harmful, and it does help a bit, but it's not a game changer. Standard multimodal analgesia with intrathecal morphine or fentanyl, regular paracetamol, and SEDS remains the backbone. Don't add 25 milligrams of dexamethasone expecting a dramatic difference.
Quick hits before we wrap. PBS September brand deletions are now less than 3 weeks away. Amoxil capsules, Cardizem CD, Actos, and Polyvisc are being removed on September 1st. Transition your patients to remaining generics now, not on the day. Your pharmacist will thank you.
And a reminder on the TGA review of Tavneos Atogepant for ANCA vasculitis. The review is ongoing due to concerns about clinical trial data integrity. If you have patients on Atogepant, continue it, but review the risk-benefit individually. The TGA will provide updated guidance when available.
Let's recap. 4 stories today. First, stepped reminders boost lung cancer screening from 47 to 75%. Build the recall system before the Australian national program launches. Second, Atogepant beats topiramate on both tolerability and efficacy for migraine prevention, but Atogepant is not PBS listed. Third, slow antidepressant tapering with psychological support is as effective as continuation and prevents 1 relapse in 5 compared to abrupt stopping. Fourth, high-dose dexamethasone for cesarean analgesia shows small improvements that probably don't change practice.
The common thread today is about doing things systematically rather than reactively. Reminders for screening, structured tapering for antidepressants, multimodal protocols for analgesia. The evidence keeps telling us that systems beat willpower.
See you tomorrow. Stay sharp.